My name is Joyce Woo. I'm a pediatric and fetal cardiologist at Ann and Robert H. Lurie Children's Hospital of Chicago and an assistant professor of pediatrics and medical social sciences at Northwestern University Feinberg School of Medicine. And actually, 50%, just to give you some sense, is actually pretty good for compared to the rest of the United States. We cite in our paper some other states that actually have even lower rates of delivery at a surgical center. With regards to prenatal diagnosis, in theory, 90% of these diseases are detectable by prenatal ultrasound. What our team has discovered is that a lot of patients are not getting these prenatal ultrasounds, specifically the second trimester ultrasound, which is probably the real gatekeeper to detecting these defects prenatally. So we've found in previous studies that publicly insured patients are far less likely to obtain second trimester ultrasound. That's a clear disparity and a clear area for intervention and improvement and policy change. Um, the second area is missed diagnoses prenatally. This is becoming less of an issue, especially for critical congenital heart defects, mostly because the vast majority of these defects are pretty easy to see prenatally on ultrasound. There are a couple like total anomalous pulmonary venous connection that do have a lower prenatal diagnosis rate, but over time, the trend of these prenatal diagnosis rates are increasing. And then the third component is what this paper is really focused on, which is even if someone is not diagnosed prenatally, how do we get them to the right care as soon as possible? And what I think is really encouraging about this paper is that we're seeing that, at least for the outcome of hospitalization duration, which is, as we all know, not the end all be all of outcomes for congenital heart surgery, but at least for that outcome still, transfer between 1 and 3 days has a comparable hospitalization duration as being delivered at a cardiac surgical center. That's really encouraging because not all patients have the access or the means or the ability or, the ability to wait after mom's water breaks to deliver at a cardiac surgical center. So I think that's a really encouraging point. Um, Critical congenital heart disease screening has been really a game changer in our field with regards to pulse oximetry screening has been a game changer in our field in terms of detecting congenital heart diseases sooner so that patients can be transferred. But the other interesting thing about our paper that we're seeing is that a lot of the later transfers, the transfers that occur after 3 days, potentially are not driven by patient level factors, i.e., how ill the patient is, but appear to be driven by hospital level factors. And that's really a ripe area for study, I think, because that makes you wonder if there's actually a systems-based issue that is driving these later transfers rather than a patient sickness or the degree of illness or comorbidity, what have you, issue that's actually driving the later transfers. So all that to say, there is a lot going on. The final thing that I forgot to mention is obviously the advent of artificial intelligence to detect congenital heart defects on ultrasound. So there are a lot of private groups that are already employing these techniques, which will be extremely useful for rural populations where their obstetric ultrasounds are often being read remotely. Where the reader doesn't have the ability to scan the patient themselves, or the reader is actually trained in radiology. These AI techniques will be really useful to increase the total rate of prenatal diagnosis.